Okay, so we're going to get into Chapter 5, Perioperative Nursing. We're going to learn about all the things that involve pre-operative surgical nursing and then the post-operative uh, process. As a nurse, getting a patient prepared for surgery is a very important role. It's an important process. Um, there's a lot of moving parts that go into it, and it's just very critical that we as a nurse we do our part in advocating and taking care of our patients. Here you have the main objectives for this lecture is going to be we're going to define the phases of perioperative nursing, and we're going to describe the immediate preoperative preparation, the intraoperative and postoperative management of a surgical patient, and then we're going to talk about the nurse's role in keeping our patients safe. Surgeries done outside the hospital that are not requiring an overnight stay is something we're seeing more and more of. These are called ambulatory surgery centers, and due to the advances in technology that we have now, this is more common, and so this makes the preoperative nursing assessment a little different than ways that maybe we've done it in the past, and it requires a sound knowledge of aspects of all perioperative nursing because a big part of our job is going to be educating, informing our patients not only about what they need to do for pre-op, but also we want to educate about the surgery itself, some expectations the patients can have, because when they come out of surgery, they're going to be on anesthesia and stuff, and they need to know this stuff on the front end. Here we have listed 6 common different types of surgery. Diagnostic, it's where we're trying to diagnose something. A good example of this would be like a bone biopsy. Curative, it's where we're trying to cure something, like maybe we're trying to remove a tumor or take out an appendix. Reparative, that could be like a wound repair. And then you got reconstructive / cosmetic, and that's like a facelift. Palliative, that's where we're trying to relieve pain or correct a problem, just something to make the patient more comfortable. But do refer to Table 5.1 in your textbook on page 106 for more on this. Okay, so let's look at some special populations to consider. We've got our elderly, our obese, and our patients with disabilities. Elderly patients are the most common patient you'll be taking care of in the perioperative setting. Just in the hospital in general, usually you just have more older people. So some things to keep in mind with the elderly is pain, the preoperative pain assessment. Kind of know the patient, understand that they may not report pain. A lot of the elderly patients don't report pain for whatever reason. So kind of understanding clues that might indicate they're in pain, like facial grimacing or acting out, irritability, body language. Also, you want to take precautions when transferring these patients because of they're more fragile because they're older, and usually the older population they're going to have a longer hospital stay, and then delirium could be something that they have due to the hospital stay, and this is often it's undiagnosed complication in the elderly following a major operation, because it just takes its toll on their body. They're out of their environment. There's a number of reasons this could happen. But keep that in mind with the elderly, and then your obese patients. The heart has a lot more demand on it with the obese patients. The book says that it's estimated for every 30 pounds that is excess weight, adds 25 miles of blood vessels that are needed to meet the demands of the body from the heart. So that puts a lot of stress on the heart, and your obese patients are also more at risk for infections due to this. Also, another complication is wound separation, disherence. I think I said that right. where so like if they've had like a surgical incision, it could separate just because of the more pressure from them being so obese. Um, so yeah, those are some considerations for these populations. Then our patients with disabilities, you want to kind of identify their needs as far as teaching, and then specific needs for like devices and things that they're going to need on the front end, so we can best care for these patients. So the three phases of perioperative nursing: you got your pre-op, it's before, um, before the operation. You're going to do a lot of education. You're going to do a lot of screening, assessing. Uh, Intraoperative, that's where it's actually the actual operation is taking place, and then post-operative. Let's take a look at this picture right here. This is kind of a big overall picture of perioperative nursing. Okay, so you can see in the bottom there it says pre-op teaching. Um, there's a ton of things to cover here with teaching, and it's and teaching in the preoperative setting is so important. That's where the teaching needs to be done, because these patients are going to be getting anesthesia, all these things while they're in the operation. So when they come out, they're not going to be teachable, or not be as teachable. And of course, they need to know these things on the front end. So let's go over some of the teaching points. So a lot of times with the patient that's getting anesthesia, their respiratory system, so they get the anesthesia, and it kind of stiffens up the alveoli in the lungs, and so when they come out, they're not breathing that deeply, and they're at a risk for developing pneumonia because of this, because the fluid in their lung just kind of pools up there. You think of like a stagnant pool water, so you kind of get this infection if they're not moving. So that's why it's important to teach deep breathing, teach them to turn, cough. You want to keep as much movement as possible, and then you also want to teach incentive spirometry. That's the thing, where you blow in and you breathe in, you blow out, and you're expanding that alveoli there. That can prevent a post-operative complication called atelectasis, that we will definitely talk about more throughout this lecture. But that's some big teaching points as far as our respiratory system goes. Now, the informed consent, that is something as well that is going to have to be done. Now, the doctor, the physician, is the only one that can sign the consent. They're the one that gives consent. The nurse can verify, the nurse can educate, the nurse can reinforce, and that's the big part of the nurse's role there, is ensuring that it's done, that the patient's informed, the patient knows what surgery they're having, and all their questions have been answered. A lot of times the doc will rush in, go over it real fast with the patient. The patient's too timid or whatever to ask the questions, and then the patient doesn't really understand what's going on. And so if the nurse recognizes that, they need to contact the physician and have them go over it again. But just know that the informed consent part, that is the physician's responsibility to sign. The nurse's is just to see that it gets done. So some assessments. Preoperative assessment is going to be big. Now, usually you have three major systems that are affected with surgery. It's usually people coming in for surgery. It's usually a cardiac, respiratory, or a GI problem. Now, we talked about respiratory. If it's a GI issue, you want to teach early ambulation. They're going to be on a PCA pump maybe, or they're going to be on some pain medicine that's going to slow down the peristalsis, and they could get a bowel obstruction. So if you teach that early ambulation, that can prevent that. It helps kind of speed that peristalsis up. And then with our cardiac patients, oftentimes, they will get something called a echocardiogram on the front end, and that's to see how effective their heart's pumping, to see if their heart can handle the demands of the surgery. And they measure something called an ejection fraction, and you want to see that 55% or greater. Um, and then some patients, if they have a cardiac history, they will get an EKG to kind of see what their heart rhythm is, because you want to prevent the big things, right? You want to prevent cardiac arrest or respiratory arrest or anything of that sort. So check out these systems, educate, and you try to identify things on the front end, and then also so they're aware before they go under anesthesia. Now the nurses, there's some lab work that'll be done, some common lab studies. Now we're talking like just basics here. This is a very general statements that I'm making because we're just talking about surgery in general, not a particular type of surgery. But anytime surgery is going to be done, there's going to be a coagulation panel and a complete blood count, a CBC. Coagulation panel, that measures your PTT, your INR, and your PT, and those are basically just see how fast or how slow your blood clots, and it lets us know how big of a risk the patient is to bleed out. Now we don't want these to be too low, because if they're too low, then the patient could have clotting issues, and they may be at risk for a thrombus postoperatively. But if they're too high, then the patient's at risk for bleeding out. So you'll want to teach them to stop any kind of blood thinners before surgery, Coumadin, aspirin, things like that. And then we'll do something called a H&H, hemoglobin and hematocrit, and a red blood cell count. We kind of measure that, and that tells us how much volume the patient has, because the patient will lose some blood during surgery. We need to know, are they going to be able to withstand this, or do they need to get a blood transfusion before surgery? Now, general numbers here that I'm throwing out is a hemoglobin, you want it above 8, and you want a hematocrit above 24. Now, that's the bottom line. You would ideally like it to be better than that, but this is general statements I'm making. Now, if the patient has low hemoglobin or hematocrit, they may need a blood transfusion. You'll need to get consent for that, and that again, that's just like the informed consent for the surgery. That'll also be performed by the physician. But that is, and then obviously over to the side here, you see the process, the nurse's role, and the big thing is staying sterile throughout surgery. But we're going to talk more about each individual aspect of perioperative nursing throughout the lecture. But just wanted to kind of go over this picture. It kind of gives you, I feel like it gives us a big picture of everything we're going to cover. So maybe it'll make sense later on when I refer back to these things. Okay, so phase 1, the preoperative nursing. So this begins when the decision has been made to have surgery. And then the nurse's role is going to be to assess and help the patient develop a plan of care. And you do that by identifying any needs or problems that may occur. You want to take a good medical history. Like I mentioned, in the last slide, big histories we're looking for is cardiac history, respiratory history. Do they have COPD? Do they have asthma? Do they have something that's going to put them at risk with the anesthesia? Are they at risk for having a cardiac event during the surgery? And then there may like I mentioned, there may be some diagnostic tests like the EKG or the echocardiogram or something that needs to be done on the front end. So a ton of education goes into once the patient's made the decision to have the surgery, that's when this process began. It's a lot of assessing, screening, and educating. So as I mentioned, we educate, we advocate, and we want to prevent as much as we can. We want to get the patient as prepared for this surgery as we possibly can. Now, this is the urgency of the surgery. So, elective is when it's planned to correct something, but it's not acute. So just because it's elective doesn't mean it's important. It just means it's something that can hold off. So you may have a knee replacement that's scheduled and it's elective and it's very important, but it's something that's not just urgent. It can wait a month or a week or however long. Urgent is just like it says. It requires prompt attention. You know, something like gallbladder, something like that. That it's got to be done pretty quick, or we're going to have a lot of complications. Going to have some infections, things like that. Emergency, that's somebody having a heart attack. That's somebody that's having a stroke. That's something that is, it's got to be done or they're going to die. Pretty straightforward there. Gunshot, stabbing, severe bleeding. Um, yeah. So yeah, that's pretty straightforward there. Okay, so informed consent. We talked about that just a little bit ago. We know that that is the physician's, that's his responsibility or her responsibility. The nurse just kind of makes sure it gets done. The nurse wants to enforce, it's going to enforce, make sure it's done. But there's 3 conditions that must be met. Information must include adequate disclosure of the diagnosis, the nature and the purpose of the proposed treatment, the risk and consequences of the proposed treatment, and the probability of successful outcome, the availability, benefits, and risk of alternative treatments, and the prognosis of if treatment is not instituted. Second, the patient must demonstrate clear understanding and comprehension of the information being provided before receiving sedative preoperative medications. If the patient is sedated prior to signing the consent, surgery may be canceled or delayed. Third, the recipient of care must give consent voluntarily. The patient must not be persuaded or coerced in a way by anyone to undergo the procedure. Okay, so keep in mind about the giving the pre-op medication before the consent sign. I could see that being a test question. Don't know that it will be, but it could be. Seems like something that somebody would like, a person writing a test would like to ask. That could delay it because the person's not in the right mind. Yeah, so I want to read over that and know all about the informed consent. Like I mentioned, it's the surgeon's job to obtain the consent. A nurse can witness. A nurse can advocate for the patient and verify that the patient or the caregiver understands. And if the patient is not informed, you want to contact the surgeon and request that the surgeon speak to the patient and always chart this. This could save you from a whole lot of trouble. If the patient wants to refuse a treatment, they need to be notified of what the risks are for refusing the treatment. The primary purpose of the informed consent process is to ensure that the patient or the patient's representative is provided information necessary to enable him or her to evaluate the proposed surgery. The admitting nurse will review the chart and ensure that the signed informed consent is present. You want to make sure that the patient does have the capacity to make the decision. And if not, the partner in care or the power of attorney can make the decision for the patient. But the informed consent is necessary in the following circumstances: invasive procedures, such as incisions, biopsies, a procedure requiring sedation or anesthesia, non-surgical procedures such as arteriography, and procedures involving radiation. It is the patient's right to refuse the procedure. Make sure to have consent available in multiple languages and have a trained medical translator. Voluntary and written consent is necessary before non-emergent surgery can be performed. For a surgical patient, a properly executed informed consent must be in the patient's chart prior to surgery, except in emergencies. A written consent protects the patient from unsanctioned surgery and protects the surgeon from claims of unauthorized operation. Okay, so read over that about the informed consent. But there you have it. Who's responsible? It's the surgeon. What's the nurse's role? Clarify, verify, witness. And then you know what to do if a patient, if you don't believe a patient's been adequately informed. We're going to notify the physician or the surgeon. Now, the surgeon will usually mark the area with a marker that is where surgery is going to take place prior to the surgery. Do not wash this off. Patients who cannot write, they can sign an X, but they must have 2 witnesses, and nurses can do this. Then there's the timed out part, and that's where before the surgery, so we're like right there, surgery's about to take place, we do a timeout, and that's where we identify the patient, make sure we got the correct side, the correct position, agreement of the procedure before incision. So we do a timed out before we start cutting. And then surgery does not provide an exception to a patient's advance directive or a living will. Okay, so patient safety is always our number one goal. So we do the preoperative health assessment. I've already talked about it just a few minutes ago. We're mainly, the big things we're trying to prevent is cardiac arrest, respiratory arrest, or bleeding out. Those are your major complications during a surgery. So we kind of, I just went through the assessment, the big things to look for in an assessment. Do note on page 109, there's a table or a box, 5.2. This is the risk factors that come with surgery. So you want to know that. You want to ensure that you have a baseline neurostatus. You want to assess the LOC and the ability to follow commands. You really want to assess every system thoroughly before surgery. That's why, because you have a baseline, because they're not going to be, they're going to be affected by the anesthesia and surgery, and you want to have something to kind of compare it to. Now we're looking at nutrition and fluid status. Nutritional needs are determined by BMI. A normal BMI is between 18.5 and 24.9. If you're under 18.5, that's considered underweight. Over 25 is considered overweight, and 30 or greater is obese. 40 or greater is extremely obese. A waist circumference in men greater than 40 and 35 in women is associated with an increased cardiac risk. So these are all important things to assess for when you're doing the nutritional assessment. Dehydration, hypovolemia, electrolyte imbalances, they can also have significant problems in the patient with comorbid medical conditions or in the patients that are elderly. So all these things, so the fluid status is important, the nutrition status is important, but another big factor, and patients oftentimes will try to hide this, is if they have a history of alcoholism or drugs. And this could be very critical because oftentimes alcoholics are malnourished. They may have electrolyte imbalances, Another big key thing with alcoholics is alcohol withdrawal syndrome or DTs. You can usually anticipate them between 48 and 72 hours after they've had a drink of alcohol. And the signs and symptoms of withdrawal is anxiety, insomnia, tremors, tachycardia, headache, GI distress, hallucinations, delirium. These can be very critical, very serious. So this is something we need to know about on the front end in case we might need to get them something ordered to kind of help with these symptoms and prevent some major complications. So, surgery is contraindicated in patients that have acute nephritis or acute kidney injury or low urine output. If there's any kind of sudden acute kidney injury, most of the time the patient's surgery will be canceled unless it's like a life-saving emergency type surgery. Patients with diabetes are at a high risk for many infections and diseases in multiple body systems because of the excess blood sugar that causes blood vessel damage. They oftentimes have multi-organ problems like cardiac, renal, peripheral vascular disease. And so if a patient's a diabetic, this needs to be identified and managed carefully during the whole perioperative period. You want to monitor for signs and symptoms of high and low blood sugar. And then if a patient has had any use of corticosteroids in the past year, this needs to be reported to the anesthesia provider and the surgeon. You want to monitor for adrenal insufficiency, which presents with hyponatremia, hypoglycemia, hyperkalemia, and complaints of weakness and fatigue. Medication history must be obtained, and you want to rule out any possible drug interactions. The medications need to be evaluated by the anesthesia provider. You want to assess for over-the-counter substances, particularly like aspirin. It is going to need to be stopped 7 to 10 days prior to surgery because that inhibits platelet aggregation, which could lead to a bleeding complication. Psychosocial, you want to look into how people cope with things. Oftentimes surgery brings on a lot of fear and anxiety, and you want to determine the extent and the role that the patient's support network is going to play. A patient's spirituality can determine how a person may cope with this fear and anxiety. And then there's just very different nuances. One particularly would be like if they're a Jehovah's Witness, they would most likely decline blood products. And so a person's beliefs should be respected and supported. Let's take a look at this question and test our knowledge. The client scheduled for knee replacement surgery today performed all of the following actions yesterday. Which action is most important for the nurse to report to the surgeon? A. Took 50 milligrams of Benadryl at bedtime. B. Smoked 1 pack of cigarettes instead of 2. C. Drank 2 12-ounce glasses of beer. Or D. Took 2 aspirins 3 times. If you pick D, you are correct. So now we're talking about the regular meds that the patient is normally on. Doing a good history on medications and understanding what the patient is taking on a regular basis is very important prior to surgery. Sometimes high blood pressure medicine and antidepressants are held prior to surgery due to the risk of adverse blood pressure results. If someone's had a recent MI or a stroke, recently ingested some garlic, garlic decreases blood clotting. And then if they're a history of, they have a history of being a smoker or they have chronic lung disease, these are things that need to be noted as well. And then another big one is to keep in mind insulin dosage. And this would be a good one to keep in mind for test purposes. Insulin dosage may be reduced. You may use 5% dextrose to prevent hypoglycemia during surgery. So oftentimes a patient will be NPO for quite some time before surgery, so they haven't had anything to eat. So they may be or that they are at a greater risk for hypoglycemia, low blood sugar. So a lot of times they might use dextrose as the IV solution during the surgery to prevent that. So keep that in mind. Okay, here's some of the preoperative medications that you may administer or see. So one class is sedatives, and some common sedatives are Atarax and Vistaril. These medications, they induce sedation by reducing irritability and excitement. Hypnotics, lorazepam, also called Ativan. You'll see that one a lot, and it's a sleep-inducing medication. Versed, it's an anti-anxiety. It's given a lot of times preoperative to kind of help the patient relax before surgery. And then you'll see some common opioids such as morphine and hydromorphone, also known as Dilaudid. And those are pain management medications. Anticholinergics, atropine is a common one you'll see, and these are given. They help the patient relax during surgery, and they help the patient also decrease the saliva secretions. It kind of dries that up. And then lastly is H2 histamine blockers such as Tagamet and Zantac. And these medications are given to decrease gastric secretions. We've already covered some pre-op education earlier in this lecture, but we'll touch on this again because this is a very important point. Education is super important. Proper education can prevent some serious post-operative complications. And remember, we want to educate on the pre-op side of things before the patient has had all these medications and their body's been under all this stress of surgery. So number one, preventing respiratory complications, incentive spirometry. You see the little device up there, the guy's blowing in the thing. And this is the thing that it helps those alveoli expand. You know, oftentimes they're kind of stiff and they're not very flexible when they come out of anesthesia. And if they're not careful, pneumonia, infection can set up there. So you definitely want to teach them. You want to teach them to inhale, hold their breath for 3 to 5 seconds, and then you want to gradually go up on the goal. As you can see, there's a marker there, and you can kind of just bump it up, and you want to just keep increasing. It's kind of like weightlifting or something. You just add a little bit more resistance each time. And you're kind of helping those lungs stay good and expanded. Coughing, you want to teach coughing and deep breathing. You want to teach them to expel their secretions, cough up if they're coughing stuff up. You want to get it up. Keep your lungs clear, and this can prevent a very serious complication called atelectasis. So, when should you have the patient cough? Say they've had a craniotomy following a hernia repair. Surgeon usually writes a do not cough order. So there are certain surgeries where they would not cough because of the stress that would cause on their abdomen or their head. Those are two particular: hernia repair or craniotomy. I would say any type of abdominal surgery. And then you want to promote motility. We mentioned this earlier, or I think we did. You want to improve circulation. So post-operatively, another big complication is blood clots. And if you'll look on page 115 and just note that box, it's box 5.3 there. Yeah, so it shows some things that will be some good teaching points to prevent some of these postoperative complications. Okay, so some important factors. We want to ensure, decrease, provide, and maintain. Number one, we ensure that the patient's been NPO, and that's just to prevent aspiration during the surgery. That could be a very serious life-threatening complication. So keeping your patients NPO when they have an NPO order is of utmost importance. Let's decrease the bacteria without injury to our skin by skin prepping. We want to provide immediate pre-op care gown, hair pulled back, inspect the mouth, take out dentures, remove them, remove jewelry, no jewelry in the OR, and that's to prevent an injury. If you have like a wedding band on or something like that, that thing can turn into like a tourniquet because you're going to have some swelling a lot of times postoperatively. So no jewelry. You will most likely, no, you will, in fact, if you send a patient to surgery, there will be something called a preoperative checklist. And so all these things that I'm naming off is going to be on the checklist. And when they're calling report or you're giving report, they're going to ask you, hey, has the patient been NPO? Do they got a clean gown? Do they have their skin prepped? So make note of the figure on 5.2 on page 117. All right. So in addition to the respiratory complications that we've mentioned, atelectasis, we've mentioned pneumonia, and another big one is venous thrombotic embolism, VTE. That is a serious complication. It's where the patient has abnormal blood clots in various places, and the patients are, they're not as mobile postoperatively, and that could put them at risk for this. So some populations or some factors that make them even more at risk is if they're obese. Patients typically are more at risk for blood clotting due to the impaired clotting mechanism, and then also blood perfusion's not quite as good oftentimes, and then they're going to have maybe more inflammation, which also increases blood clotting. If you're over 40 years old, you have a history of cancer, if you're not mobile or not as mobile as you were, if you have a decrease in your mobility or spinal cord injury, which would go hand in hand with that, and if you have a history of pulmonary embolus or blood clots in the past, history of swelling, oral contraceptives, that would be a big one to take note of. If someone's on birth control, that does increase your risk for blood clots. Smoking and a history of decreased cardiac outputs, like I mentioned with the obese people. Decreased cardiac output, you just don't have as good, the blood's not flowing as good as it should, so it's more likely to throw a clot or clot set up. You had a hip replacement, knee replacement, or any type of fracture, that also makes you at risk. So keep those in mind. So how do we prevent VTE? Well, we want to get them up, get them moving right after surgery. Increasing that mobility is going to increase the blood flow. It's going to help prevent them clots. It's going to help prevent. Also, it's going to help prevent all the other complications like the respiratory and the GI complications that could come after surgery. So, always a priority is early ambulation post-operatively. TED hose, that's the picture in the middle. This patient's got these tight stockings on, and that helps with blood perfusion to the lower extremities, and also the compression devices that's on the patient's lower extremities. They're hooked up with this little machine, and it kind of massages their calves, and that's a good thing that you'll see a lot to prevent any kind of blood clot. And then leg exercises. So all these things are critical to know. They'd probably be really good to know for testing purposes, as a nursing intervention on what you would do postoperatively to prevent VTE. I referred to the pre-op checklist a little while earlier, and here we have a slide on it. So let's run through this. We want to ensure all documentation, preoperative procedures, orders are complete. You want to check, see if the consent's on the chart, and it's complete. Inform the patient that area will be marked before the procedure begins. So we talked about the area where surgery is going to happen. They're going to mark it. And then you want to document the allergies, the height, and the weight. Make sure that allergy band is on the patient. So that's big. Allergy band. If they have an allergy, make sure that band is on the patient. That could save the patient's life. Continuing with the pre-op checklist, you want to ensure all the lab work's been done, the diagnostic test. Remember, we talked about earlier in this PowerPoint presentation, we talked about the coagulation panel and the complete blood count. So you want those lab works done. You want EKGs, echocardiogram, all those things that I mentioned earlier. You want to document. You want to report any abnormal. Maybe the patient's going to need blood, or maybe there's something that needs to be done, or maybe they have a heart dysrhythmia that we discovered that needs to be documented. Right? I mean, these things are definitely important and need to be documented. You want to report special needs and concerns. You want to remove clothing and provide a gown. Leave valuables with a family member or lock them up. Tape rings in place if they cannot be removed. And then ensure that the patient is wearing the ID band. Some more on the pre-op checklist. Okay, so we want to remove all the devices we have listed here: dentures, prosthetics, hearing aids, contact lenses, fingernail polish, artificial nails, jewelry, and rings. Now, electrocautery may be used to control bleeding and increase wound healing. What that is, that's like a little laser type device that cauterizes the vessels, that keeps them from bleeding, and it can also, and like I said, it can help with the wound healing. It provides blood flow to those areas, but this can it can also cause superficial burns if its contact with metal is made. So that's one reason why we don't have them wear some of these prosthetic devices. Now, nail polish, we want to tell them not to wear nail polish, and the reason for this is we can't assess their perfusion, the color of their nail beds. It's hard to tell if their nails are painted, pink or blue or something. It's hard to do that assessment there. If they have hearing aids, know this, that they can keep their hearing aids in or glasses on until the administration of anesthesia to help with communication. A lot of these patients are dependent upon these things to communicate, so we'd let them wear them until the anesthesia is given. Now, and I mentioned this earlier about the rings. We don't let them wear the rings because of if you have decreased circulation, or maybe you have you're getting IV fluids. There's a couple of reasons why you might have swelling, and a tourniquet like that ring is going to become real tight, and it can turn into like a tourniquet. It could cause some circulatory issues, and then it may need to be cut off if it can't be removed. You can soak it in ice water, lather it in soap. There's other things you can do to try to get the thing off if you're having difficulty.